See, kindly go on the slideshow mode.
All right, thank you so much, Vinay. And yes, it's going to be a very interesting session, through our webinar series, which is on fighting the COVID pandemic, a nurse's perspective, and hearing from the nurses themselves. We have two eminent speakers today. We also have our very eminent moderator, Vinay will introduce later. My name is Varun Kumar. I'm the National Sales Head for IPC Health. But
Varun,
before
may I request you to go on full screen, the slideshow, please?
Yeah, and before I start, we start our webinar. I thought maybe I'll take a couple of minutes to, introduce IPC Health and what we do and what we offer. IPC Health, as an organization, it offers a digital learning and development platform which helps the hospital support their staff with all the training lifecycle management, L&D, which helps them improve to quality of the delivery of care. And the high level, IPC Health is a comprehensive learning management system, which has quality compliance training module, onto it. We also have, all the emergency induction module, available, to be accessed. Some of the key features which we're going to talk on, in the upcoming slides is going to be on the online and offline training management system feature, the IPC Health communicator, and of course our content marketplace where you all can access the various books and journals, some of the soft skill courses which are available, and also some of the CPD courses, which we are going to talk about in our upcoming slides. We started our journey, officially launched early this year in the January before the pre-COVID era. And as we speak, in the last 10 months, we have now been, our service has been used by 110 hospitals, and more than 22,000 users are being benefiting by using our proven solution at their hospitals, and you can see some of their logos. Yes, as an organization, IPC Health, and an offering, IPC Health endeavors to continuously improving on a product which helps the hospital deliver, better, training and delivery system. We are excited to announce some of the key functionality and services today. The first in the league is the IPC Health Communicator. Like how we all have connected today through the Zoom on a virtual meeting or a webinar, we have integrated Zoom onto IPC Health so that you don't have to use Zoom separately to conduct your meeting and webinar in the hospital setup. And not only that, it also allows the admin or the quality head or the nursing superintendent or nursing educator to view and download the record once the training, when those meeting and webinars are over. Yeah. Second in the league, which we are announcing, is our IPC Health Classroom feature, which allows you to conduct your training online. That's what today during the pandemic, it is so difficult. We're hearing from the hospital that they're not able to conduct their physical training, which used to happen in the hospital setup. You can now, with IPC Health Classroom feature, do those training online. And not only that, it also helps you to take the assessment, the pre-test and the post-test, and have those report, in the dashboard, and it can be used as a part of the audit trail and compliance purpose. Needless to say, it gives you the a flexibility of taking up your training from anywhere and at any time, and that's the flexibility it provides, and that's a challenge which most of the hospital staffs are facing today. The third and the most important piece, which we already announced today, is our collaboration with the Royal College of Nursing. It's the subsidiary of Royal College of Nursing UK, very reputed organization in the European countries. It's a 100-year-old organization. I'm sure many of you would be aware of this. If you're not, you will be thrilled to know that we are launching, in association with RCNI, their CPD, the Continuous Professional Development Certification Program, which will be available for you to access from this, either at the end of December or early January next year. To give you the gist of some of the modules on this certification program, how will they look, and which will certainly help you boost your career journey, as and you'll gain a lot of credentials. The modules could be on the reducing medication errors in the nursing practices. It could be prevention of the surgical site infection. It could be on preventing the catheter-associated UTI infection, and so on. And you'll have a whole bunch of these modules available for you to grab. And guess what? All of this is available in India for you as an individual nurses, available for just rupees 1,500, which includes taxes. What it is, so what it means, it is an annual subscription which comes for a 12 months duration. On the day of sign up, you get 30 courses, and every month thereafter we will add 3 new courses every month to keep you engaged. And those who are interested, we have put our email ID on the screen, info@ipchealth.in. I repeat, info@ipc.in. Write to us, and we will reach out to you and discuss more on this RCNI CPD certificate program. We also encourage you to visit our website and access COVID-19 Resource Center for free online courses, free webinar by our industry experts. As we speak, more than 60,000 users have been already benefited, and we know that you will benefit it from that too. Yeah. As an organization, our purpose is to improve healthcare in India by spreading knowledge through technology, and we want you to be a part of that journey. Today, we are into 100 hospital and serving 22 users, but we want to be in thousands of hospitals in the next 2 years and serving millions of users, helping them upskilling themselves and thereby enabling them deliver better care in India and in Asia. At the end, before I hand over to Vinay, just a recap. You can take down our email ID info@ipchealth.in. Thank you so much for your time, for basically listening to me. I'll ask Vinay to, take the further proceeding and introduce Ms. Antonia.
Thank you very much, Varun. Without much delay, to all my participants, I would like to call upon Antonia Pushparaj. Ma'am, we welcome you to take it forward our webinar session. A brief introduction, what all of you can see on the screen. Founder of Jyotirgamai Foundation, an institution that works for health reformation in community, especially adolescent, through life skills training, coaching, counseling, and mentoring. She's also a NABH Principal Assessor for Hospitals, Emergency Care, Nursing Excellence, eye hospitals, and SHCOs. Auditor to Niti Aayog project, Ayushman Bharat, in aiding national ranking of all district hospitals in India. She's Director, Development and Education for Patient Care and Nursing Services, Faculty for Hospital Management in the MBA, Advisor cum Chief Learning Officer, Expert Advisor to NABH Standards Implementation. The list goes on, ma'am, and we welcome you. It's a great pleasure and an honor to have you with us. I request you to do the screen sharing. Varun, please go ahead and stop the screen share. Ma'am, welcome once again. Yes, ma'am, we can see your screen, and you may please go ahead in the slideshow mode.
Good afternoon. Am I audible?
Yes, ma'am, you are.
Thank you so much for that wonderful introduction, Mr. Vinay. Also, I would like to thank Mr. Varun, Dr. Renu, and your team for giving us an opportunity to be the voice of nursing on a global platform. So, I am privileged to be associated with two of my colleagues with great repute. Ms. Lizzie John, who hails from a vast experience, who takes with her the vast experience of more than 25 years of global experience in nursing, services, education, and also nursing research. She's also into education sector in nursing as vice principal of a Faith Institute of Nursing. She is a registered nurse from American Mission Hospitals, Bahrain. Also, She was assistant lecturer, Ramaya Institute of Nursing and Research, which is a great institute of repute in Bangalore. She has a lot of awards and accolades to her credit. She is the recipient of prestigious Florence Nightingale Award in 2017, also Global Nurse Award in 2013, Award of Excellence in 2012. She is instrumental in achieving NABH accreditation and Kayakalp Award for the institution. It was a privilege to share the platform with her on various seminars and conferences as a resource person. She also has published a lot of articles and research papers. Welcome you, Madam Lizzie John. And she's currently working as nursing superintendent at Ramaya Medical College Hospital, Bangalore. And also she is a Karnataka state member of the Karnataka Health Task Force for Postgraduate Education, that is MSc in Nursing, in the wing of Medical Surgical Nursing. And also she holds the degree in hospital, a diploma in hospital and healthcare management. I'm very privileged to be associated with Madam Akama Abraham, who is a general manager, and also she heads the nursing services at the prestigious Institute of State of Kerala, Trivandrum, Kerala Institute of Medical Sciences Health. So she has 28 years plus service abroad and also in India. For more than 5 years in nursing services nationally and internationally accredited hospital. She has facilitated international healthcare accreditation in very well-known international accreditation certifications like JCI, Canadian Accreditation, ACHSI, and etc. Also, she is associated with UNESCO and an IRCA, that is, we all know that it is Internal Registry for Certification of Auditors. So ISO 9001 and 2008. So I'm very privileged to be associated and as a moderator, but they are my panelists. They bring with them a lot of experience. And apart from that, during COVID time, these two hospitals really were in the front line for caring for patients, and they were listed in our Ministry of Health and Family Welfare for caring for COVID patients. So as nurse leaders from great institutions, they hold a lot of experience with them, and welcome to both of you. So the first one, what I am going to deal with is that nursing during pandemic. So we know that this was unwarranted situation that we had during our unwarranted. 2020 really became an international year for nurses because though the World Health Organization declared it as International Year for Nurses as the 200th birthday of the founder of modern nursing, Florence Nightingale, but COVID really tested the resilience and agility capabilities of nursing in India and also globally. So we are going to discuss about, myself would be discussing about the communication in during COVID and post-COVID situations, and also challenges what nursing is facing that will be dealt by Madam Lizzie John from Ramaya, and also how they were prepared and what are the protocols that they carried, what lessons that we learned from this great experience for our post-COVID times. So the presentation, communication, we know that when it comes to that, it has to, this seminar, the topic, what I'm dealing with regarding the communication in healthcare during and post-COVID times, it is divided it into nearly 6 divisions. So introduction, role of communication, barriers of communication, communication strategies, and how we can approach to effective communication and also effective listening strategies where our words fail and how listening can help us. So communication during this time, before we proceed, we know that how this COVID has changed. There were great times where we had great interactions with our team members. We had the interaction with our patients and families. There were no PPEs. There was not only mandated, it's not that always, you had to wash your hands. We had our infection control protocols protocols, everything gets distorted at the time when we were hit by Corona-19 virus. So there, the distancing, the social distancing started, and so much of influence, so much of stress was given on our practices, infection control, and also the stress what people had to carry out. And there was so much of problems that one had to go individually and also, professionally, including their familial environment. So the new normal, how are we going to handle this? So the communication, if we have to take it particularly during COVID and post-COVID times, they must be successfully implemented to instruct, inform, and motivate appropriate self-protective behavior, update risk information, build trust in officials, healthcare people, and also dispel rumors, because we are bombarded with a lot of information, wanted and unwanted, from social media and also the television. However, responses to COVID-19 risk information are influenced by our existing psychological, social, cultural, health, and socioeconomic factors, which greatly affect how individuals interpret health risks and communications, as well as their willingness to act accordingly when they get such information. Ideally, pandemic communications maximize the public's capacity to act in an effective partner by encouraging prevention, promoting containment, fostering resilience, and also, recovery and getting back to new normal. So, dear friends, when it comes to the role of, that how that transformation, rather, the change happened, we were isolated. Our team were the team dynamics, were actually distorted. People had to work in isolation, and even when we interacted as a team, but there was so much of social distancing and also PPEs around us, we lost human touch and empathy, which we used to convey through our touch, and maybe a handshake, maybe, friends, a professional hug, those things. And then everything, our from head to, head to toe, we were covered. And these were sometimes challenging for people to have even uh, uh, their normal activities of day-to-day life when they were in the professional environment. And also the distancing caused a lot of changes in our technology, including telehealth, telemedicine, using electronic gadgets to monitor the patient through distance, and artificial intelligence, introduction of robotics. All these things were part and parcel of this COVID. We had to take care of the patients despite of all challenges. This was not the battle which we fighting, which we were fighting in the battlefield, but it was with the healthcare workers and also our social systems. Before we get into communication in detail, I really would like to know, with this perspective of we have to understand communication during and post-COVID times with two perspectives. One is factors affecting the acceptance of public health messages, which are influenced by environmental factors, socio-cultural characteristics, language barriers, and also the personal and societal preferences, different attitude towards public health intervention also. For example, now we are seeing that during Diwali time, how people are gathering, whether, all our protocols which are given by our international and national guidelines are just gone away. We are seeing that. Also, people are hesitant to use masks and social distancing. So how we accept the guidelines which we are given, which are given to us to follow, irrespective of that integrity, how much we exercise, how much we practice, how much we foster, encourage others also to implement in our day-to-day activities. And next one is, communication is the core of any human interaction and relationship. But during pandemic communication, this communication strategies need to be looked in with this framework, like building and maintaining trust. That is very important. Communication strategies are most effective when not based on misconceptions. They need to be very objective and based on facts, based on evidences, based on scientific proof. Plans should be made from the perspective of the targeted population. So how are we going to communicate to elderly? to vulnerable patients like, pediatrics and antenatal mothers who are going through delivery, and also sensory deficit patients. How are we going to? And whether it is age-specific communication for pediatric clients, and also normal patients and patients who are unconscious. These were few challenges which we faced. Messages must be sensitive. That is very important. So messages, whatever we convey, they should be uniform. They are based on evidences, and we need to exercise that sensitivity in our communication and relevant to the audience. So if we are communicating to rural population, how we are communicating, educated, and also illiterate population, urban population, people who are working in IT, people who are working in front lines, and how this is so much culturally and professionally led sort of like guidelines. So communication must be integrated. So whatever the higher authorities, the government policies, they were communicating the same thing, that needed to be communicated from the top management to the middle and to the people, those who are in the front line, and everybody had to speak the same language. There was so that there was synchrony and there was uniformity and there was more acceptance. So being prepared, building rapport and trust, having dignified, respectful in conversation, responding to emotions adequately and appropriately are the keys during and post COVID times. So here I would like to say that resilience, whenever some adversity hits, everybody considered that this COVID, it was an adversity in human life. Maybe our generation witnessed this. So whether every adversity in life comes because it wants to disrupt us, no. Sometimes it comes to clear our path. So COVID had a lot of positive aspects also that we will discuss it later. But resilience and agility, these were the two human capabilities which made people to bounce back and live beautiful life, which is the gift the nature gives. So resilience is accepting your new reality. You can't change it, even if it is less good than the one you had before. You can fight it, you can do nothing, but scream about it, or that what you have lost, or you can accept that and try to put together something that's good. This is what said by Elizabeth Anania Edwards, American attorney, a best-selling author, and a healthcare activist. So, dear friends, the healthcare, when it comes, the highest manpower in any hospital, it is nursing. Nursing comes from the word nurturance. So there is no difference between mother and the nurse. Both, the function, most of the time, they are connected. So this nurturing profession, which is the second oldest in the world as a profession, it is composing of it composes compose of all these factors like caring for human relationships, caring for human life holistically, human connections, because she's not only a nurse, she's also a advocate, she's a care provider, she's a communicator, she's an educator, various roles a nurse carries, and she has to coordinate her care. It is not a nurse cannot work in silos. She has to coordinate her care with other departments, with doctors, with other maybe IT, maybe with front desk and medical records and clerical staff, laboratory, radiology, and all. She need to have focus despite of all challenges. A nurse, one who spends the highest time at the bedside of the patient, she need to be focused. Comparison. Compassion, that is the compassion that is very important. That is the core of nursing. Communication, it is the heart of any relationship. Appropriate communication. Decision making, because everything is clinically, whatever may be the good, the best can happen for the patient. The good clinical outcome is the best outcome one can have when patient comes. So decision making, whatever happens at the top level, one is the implementation, and also her leadership decision making, and the nurse one who is the case manager at the bedside, her decision making, communicating these decisions, and also getting collaborated effort, collaborated appreciation and encouragement from other team members, that bring a lot of the good outcomes in patient care. So here I would like to tell, when I say that WHO says health is a complete state of physical, mental, social, and spiritual well-being, and not merely an absence of disease or infirmity. This is Alma-Ata Declaration, which was given by WHO in 1978. So we need to understand, to commemorate, to complement this concept, I would like to support this statement by the great nursing theorist Lydia Hall, which she has given the 3C model: cure, core, and care model. Here, the person, the body, and the disease. The disease is considered as the cure, and the body, it needs care, and also the person, the therapeutic use of self, that is very important. That is the core. So we need to understand healing always happens within, and treatment, whatever comes from outside, that should heal a person holistically. So this healing can happen. It can, which can start from the core and through the care of a nurse, and which will bring the ultimate cure for a person. Now let us move on to role of communication providing care to COVID patients. Dear friends, here I have 6 principles: the communication between healthcare providers and patients' families during COVID-19 pandemic. There was a risk of communication and uncertainty. The goal of care, we had to decide it very specifically, because we did not have appropriate guidelines. It was a novel coronavirus, so we had to go back. A lot of studies had to be done, shared decision making, and breaking bad news. That was, we have seen how our loved ones were saying, bidding farewell to us. It was so much for us to bear. So breaking, how these healthcare professionals, they were crying. We have seen how doctors, nurses, our laboratory technicians, and police, how they were handling the dead bodies, and how much emotionally they were affected. It was a very saddening sight to see. Grief, loss, and isolation. This corona has brought these 3 things. Though it says that is a very negative emotions, but it had a lot for us to see, that we will see it at the end. Core communication skills, here where we use a lot of verbal skills, but non-verbal modality, social distancing, and without touching, how we had to communicate, empathy, compassion. These were the challenges. Healthcare provider wellness and stress, that was utmost important, because if I am full only, I can always pour out of my cup. If I am happy, if I am calm, if I am composed, if I am compassionate, then only I can really deliver that positivity to my patient whenever I care. So when one person is going through a lot of stress, and stress always affects the well-being of a person, this was another challenge healthcare worker had to face. The second one was process of communication with patients and families during COVID-19 pandemic. Many healthcare providers had to use communication technologies. We were not prepared, to use telehealth, telenursing. It was an extended and expanded role for us, but that just, hit us. We were not prepared how to communicate through telephone, through telenursing and teleconsultation. We had to learn that. Support in adapting the core communication skills for in-person encounters to these virtual encounters, effectively assessing patients' nonverbal cues, emotional states, and understanding. Third one is teaching and assessing communication during the COVID-19 pandemic. This was a great challenge for the trainers and nurse educators, and also nurse leaders, how they had to equip, because one side, you had the infection rate which was going, another side, your core nursing team was getting infected. Third thing, we really had less literature to support how we have to combat this. And then next one, getting infected, and you're losing, your very critical, area staff. And so online communication, but still, nursing leaders were very resilient, and they really maintained and managed the situation so beautifully well. So online communication skills, teaching, and clinical learners not seeing patients, that was another challenge. How they had to see clinical examination and all becomes a challenge. So that was a problem. Everything doctors and nurses, they had to do virtually. And workplace based learning, which was classroom, that was moved into virtual. That was another one. And virtual communication assessments, maybe the digital thermometer, the web cameras, and also the digital stethoscopes, what they had to use. And this really created distance, but still we had to pave that path into this difficult way. So research on communication in healthcare during COVID-19 pandemic. So if we really see whether there were experimental studies or whether there were descriptive studies or whether there were quasi-experimental studies, because we did have one side, we had the opportunity to conduct a lot of researches, but another side where nursing professionals or healthcare professionals, there was a dire need in the patient care area. So research somewhere, it really got affected. So research focus, conducting research, and also presenting research with all due respect to whatever the research came out during COVID, that really rendered a lot of learning points, life experiences for us to carry for in post. We really need to carry those lessons during our post COVID times. So policy implications for communication in healthcare during the COVID-19 pandemic. So policies, usually they come from the government and also, international national bodies of health and wellness. So policies needed to be created to manage evolving scenarios. A scenario was changing. We really did not know whether vaccine is available, whether the therapy which were available, the usage of various drugs, and the quarantine and social distancing, how much we had to do. Simple example I want to tell you: N95 masks, how many days that we can use? Should we sterilize it? What type of sterilization? Everything, all these simple things which we never thought, but this COVID made us to think in all those aspects. That is the beauty of it. And we went to the micro level of our deep reflection and thinking, and that has given us a lot of learning. Efforts are needed to reinforce hospitals and supply chains in the context of insufficient public health infrastructure. That was reallocation. And surely, one of my panelists, they would be handling this, how they had to practice rationing, that is, reallocation of resources, how they did it. Surely, they have a great story to share with us. To effectively navigate this challenge, individuals, teams, and systems, we needed, to communicate effectively. That's why it becomes very important. A call to contribute to communication in healthcare during the COVID-19 pandemic, that is very important, because whatever we learned during this COVID time, we have great stories to share with our generation and all the generations to come. So let us learn whatever this navigation path, we had to pave through. And dear friends, we know that barriers of communication in our theory we studied, it is environmental, psychological, social, and physiological, barriers, physical barriers, all these things. But this COVID, whether it really gave us, some sort of like challenges, what we had, shortage of experienced nurses in the hospitals and clinics, shortage of personal protective equipment and substandardized PPEs which were provided, unavailability of accommodation and transport facilities for healthcare professionals and frontline workers. That was another challenge. Inadequate quarantine facilities, and there was mixture, and also there was a spread of infection. Physical exhaustion and mental stress, which needed to be addressed on a very great note of it. And also, it was an unpredictable situation. Lack of health insurance coverage and financial burden at home due to lockdown, and many people lost their jobs. Layoffs happened during this time. Concerns regarding personal safety and security at workplace and in the community, as well as concerns regarding the safety of family members, was another issue where people needed to know that how should I protect myself, and also how can I protect my family members. So lack of counseling in distress, communication gap between the hospital authorities and nursing leaders, inadequate supportive services such as food and other facilities while on duty. And the nurses especially, it is led by women professionals. So they are during menstruation time, how did they manage? During how did they attend to their nature calls? All these things needed to be learned. There was a great sacrifice from them. Hats off to them. Involvement of workers, unions, and politicians with selfish motives also did happen. A lot of strikes, changing guidelines of care for COVID-19 patients from global health organizations. Today we had one, and next day we had the different strategies. So infection control people, nurses, and also the management, we had our own challenges. Now let us come to the communication strategies to the new normal. We know that the visual signs which we had, and social distancing signs, barcode scanning devices, increased hand hygiene measures, usage of digital stethoscope to listen to the lungs and heart, a web-based camera to look at the ears, throat, and skin, and a tool to measure body temperature without having direct contact, also challenges. Another one we had was the negative stigma and discrimination against those infected with or suspected of having COVID-19, and even doctors and nurses were refused to give, they were asked to leave the premises because the society thought that, they were infected, and even rentals, the rental services were not given to them. A lot of mental stress, and the healthcare workers and their family had to go through this. Telehealth, telenursing, artificial intelligence in nursing, robotics usage in nursing really strategically improved. Usage of non-verbal and verbal communication, including physical touch, eye contact, gesture, silence, facial expression, posture. To develop the nurse-patient relationship, these were the strategies which were incorporated. This allows for the expression of sympathy. Sympathy, that can be seen, though, there is a social distance, but still, the compassion and empathy and the kindness can be communicated through our nodding, maybe, the eye contact, and also, the respectful silence, pause in between, the tone, the voice, that what we use, everything, it can be communicated. And always, the tone and the silence can be dignified, can communicate respect and dignity. Usage of technology, the concept of caring may change, and virtual speaking may become more dominant than in personal interaction in coming days. This is going to be one of the challenges what we are going to handle. So this is the new normal, how we are well equipped to handle ourselves with the inventions of artificial intelligence. So whether nursing is prepared for this, how much we are prepared for virtual listening. So now, strong therapeutic communications, when we come, the foundation of strong therapeutic communication has to be based on making patients feel safe. That is very important. Highlighting the positive experiences. We all have had our own experiences of various things, negative emotions, but can we build up, something on positive? So that, the more you magnify the positive becomes more. Taking care of communication staff, that is very important. One who communicates with the patients, they need to be peaceful, they need to be calm, they need to be cared for. Then only, the positive emotions get transferred through your communication staff to the patients. Honoring healthcare workers, that is very important. And we really did witness, such a type of very heartening sort of like gestures during COVID time. And preparing, building rapport and trust, having the conversation, responding to emotions, these were few things. Now, dear friends, we are coming to the communication approaches at the time of planning contingency, which is very calmer, and during critical time, which is share, and also at the time of personal loss, maybe during the death, and when we are breaking down, where we are going to use the love approach. So this is what globally widely used. So I will just,
Ma'am?
because of short of time, I'm going to go through it
Yes,
later,
ma'am.
yeah. The karma, that is catalyst for change, afterthoughts, listen first, then diagnose. M stands for make an agreement, and E stands for set reasonable goals for the next follow-up. R is establish self-care strategy. So this shared approach can be used during crisis, where yes is, you have to share the guidelines, headlines, what it means for patient care that need to be communicated effectively. Affirm the care that you will provide, whatever it may be, what you are going to do. May the patient and the family know that what you are going to do. Respond to emotions is very important. This comes, beautifully in all three: calmer, share, and love approach. E is empathize. Share the same rule applies. Emphasize that the same rule is applied to everybody, because that is what the uniformity of care. Next one, the love. This is actually based on Hawaiian, forgiveness prayer, which is used by various hospitals. We call it as Ho'oponopo. So this is what the prayer, which is love. Love is lead the way forward. O is offer the things that matter most of the people. And maybe, you have to say, I'm sorry, I love you, I forgive you, and I let you go. Always, please forgive me. And these are the things, that at the time of when personal loss is happening, love approach is used at the time of death, and when family is losing their loved ones. And E is again, V is validate what they want to say. You have to repeat it. And then E is expect emotions. So dear friends, working with restrictions really had it a lot of challenges on the compassionate communication that happens to be the core of any relationship. Nurses in this new normal have to adapt their skills to remote communication. That is very important. That remote communication doesn't mean that we need not be empathetic and kind. We need to explore those strategies also. Rediscovering the basics of communication, effective communication, because basics will never change whether it is virtual or whether it is physical communication, whatever we have. Expressing empathy without using facial expressions, that already I have told you. A conversation should not follow a script, but you can have this calmer, share and love approach, because that might help us what I should do next, so that it becomes uniform for all the patients. Empathy is the central to effective communication. Nurses' verbal skills need to become sharpened. That's very important, because tone can communicate quite a lot of things. Barriers to effective communication can be considered, like use of jargons, culture and language differences and all we have learned, that can be avoided, because we need to be very simple, specific. We only communicate clearly to inform and instruct and educate the patient. And we should never underestimate the power of effective listening, meaningful silence, and therapeutic touch. So, dear friends, when it comes to listening, a few slides, I want to tell. This is all we have learned. We have to listen, not to talk, but to listen to person with empathy. We need to relax, and we need to listen and put the speaker at ease. Remove all the distractions. It is one to one. You are completely mindfully, you are with the person. Empathize to understand, though it contradicts with your view, but be patient to listen to that. Avoid personal prejudice. Be impartial, be non-judgmental. Listen their ideas also, because once we come to that consensus, our caring strategies can become better. Wait and watch for non-verbal communication cues. You have to face it. Use multiple channels of communication. Trusted and credible information resources need to be used while we are communicating. Community capacity and resources need to be used when we are communicating, because the individual comes from the community, so that your communication becomes very strong when you use these community resources. Strengthen personal relevance to communication. Build self-efficacy and trust, that is the core of any communication. Ensure effective and integrated communication. Consider the listeners while communicating with vulnerable patients. Use communication strategies that are most effective when not based on misconceptions. So, need to be evidence-based, need to be scientific and objective. Your plans should be made from the perspective of the targeted population whom you're talking about. So I would like to, end this talk by giving the quote of our founder, modern nursing, Florence Nightingale. She says, she is the first biostatistician. She is the founder of modern nursing, and one who brought revolutionary changes during Crimean War. She was called as Lady with the Lamp, and this year is 200th birthday of hers, universally celebrated as International Year of Nurses. So I never gave or took excuses. Nursing is a progressive art, such that to stand still is to go backwards. So we need to move forward, and this adversity and agility has so much to teach us. So what we have learned, that we will come back later. Thank you so much for your patient listening. And now I would like to introduce my esteemed panelist as the second speaker, Ms. Lizzie John. Over to you, Lizzie.
Thank you, ma'am, for that introduction.
You're welcome.
Yeah.
You can share your screen now.
Yeah, if you have you stopped sharing? You're still sharing it, ma'am. Can you just?
I'll just tell. I'm unable to do that. Yeah.
Am I audible?
Yes, you are.
Yeah.
You are
Is
audible.
my slide is being
Yes,
projected,
your screen, you are visible. Your screen also
right?
is visible. Yeah.
Okay. Thank you very much, ma'am, for that wonderful introduction and the topic that was shared to all the participants. May I go right away to the topic that we are going to discuss today regarding how we fight the COVID pandemic as a nursing perspective, and what are the challenges mainly that we had, just a minute.
Yeah, your screen is visible,
I'll
madam.
just go to my topic. Just a minute. Just hold on. Yeah, is it visible now?
Yes, yes, it is
Yeah.
visible.
Okay. Now, why challenges did we face? India is, it has got enormous number of beds which are available and ventilators which are available. So many, facilities are there in India. But why did we face? Why this COVID-19 was a challenge? It was a challenge because there was no pre-existing scientific data on how to care a COVID patients. And moreover, the spread of the virus was very exponential. Nobody could actually, understand why the spread, how the spread is happening. And there was a few guidelines which were there, but still it was exponential. And moreover, the media coverage that we have seen, lot of people were involved in that. When certain hospitals are not providing appropriate care, when there was death occurring, the media coverage was too much. So that was the greatest challenge we, the hospital people, were facing when we were going to treat these COVID patients. Now let's see what are the challenges that we at Ramaya faced in setting up a dedicated COVID hospital. We really faced a lot of challenges when we set up a COVID hospital, because it was in the month of March. I will be speaking very practically what we went through in the month of March when we started. Management decided that we will have a COVID dedicated hospital, and we started with a 100-bedded hospital where an Ayurveda hospital of Ramaya was converted to dedicated COVID hospital. You know what all challenges we could face, because it was a different setup. Everything had to be put in place. The beds had to be spaced, the oxygen lines has to be put into place, suction has to be put in place. The way Ayurveda hospitals functions is different from the, so everything was set in place. And everybody, the staffs, the healthcare workers, everybody was wondering whether India will have so many cases, whether will this COVID cases be there in Karnataka, will it be there in Bangalore? Finally, it ended in Ramaya also. It was on June 20th that we had the first patient who was COVID positive. And this 100 dedicated hospital, then because the surge had increased, and our management was pleased to provide the financial funds to the PM fund and the CM fund, and also to set up a 200-bedded dedicated hospital. That was also not sufficient. The number of cases started increasing, and then we converted it into a 500-bedded hospital. So you might understand what all challenges we went through. I'll go through it in detail when we go through the next slides. So we really faced a lot of challenges while we were setting up this dedicated COVID hospital. And we had the staff entrances to be changed from the where these COVID patients were entering, so that had to be barricaded. There was a separate entrance which was made for the COVID patients to enter, because that can that lead to the transmission of infection, so that we wanted to prevent. Lot of changes happened on the way of when we had to set up the dedicated COVID hospital. And there were a separate place for donning, doffing. All this arrangement had to be done. And when this COVID dedicated hospital was established, there were a lot of inputs that we received. We went across, planning was done, lot of organization, lot of ideas were put in order to make sure that we will we will not lead to the spread of the infection to the other healthcare workers, but make sure that it has been contained, and we will be able to provide the best possible care to the patients that we care for. So those are the challenges that we faced when we were setting up the dedicated COVID hospital. And then we had a lot of changes in the infrastructure also. The infrastructure had to be changed. We had to space the beds. It cannot be like the previous spacing of beds had to be done. So the number of beds that can be accommodated would be less. Then new wards were dedicated only for COVID wards. Then CCTV had to be installed. War rooms were established, because it is from there the doctors can give the advices for the other people who are working on the ground to the doctors who are working on the ground. So war rooms were created so that counseling can be done for the patients. So a lot of infrastructure changes was done, so that there were donning area was separate, shower area was separate. Then we had the doffing area. Initially we started with one area. That was not sufficient, because the number of healthcare workers who were treating the patients increased. So we had to increase the doffing area also. All these infrastructure changes went by one by one. One more infrastructure changes which we done was all non-touch doors were created, so that will not be a source of infection. And we had challenges in equipments and supplies also, because we had to shift all these equipments and the supplies which were required to the COVID area. And supply was also issues, supplying of food, supplying of linens, supplying of all the other issues. For example, the stock which has to be there. All these issues we faced when we were setting up this COVID hospital. Then the guidelines kept on changing, and we had a lot of guidelines which were there, guidelines from CDC, guidelines from WHO. We had guidelines from Ministry of Health and Family Welfare. It changed, it rolled as the as the pandemic was moving on. So we had to adapt to all these changes. We had to train the nurses, all the healthcare workers, and how they have to take care of themselves. This is all the challenges that we faced in setting up the COVID hospital. Next is the procurement. We had to procure, because our hospital, even it was 500 bedded hospital, we had 68 beds, ICU beds, which was dedicated for the COVID patients. So we did not have that so many ventilators. So a lot of a lot of people came forward, a lot of companies came forward in order to provide these ventilators for us, and even government also provided us the ventilators. So these ventilators were installed, but we had challenges in training the nurses, because these ventilators were new, they had to be trained, they were on duty, how to train them, what is the time that is scheduled for them. That was also a challenge for us. PPE, again, PPE was also a challenge, because selection of the quality itself was a challenge. Based on the FDA, we made sure that these PPEs are comfortable when the healthcare workers wear, and also the size also was a matter. We had people who very, very stout, and these PPEs would tear off when they wear it. So the size was also an issue or a challenge that we faced. And wearing of mask was a real challenge for the nurses, because that would initially they used to really have that breathing difficulty. They used to complain that it is unable, but in course of time they got used to it, and wearing of mask and shield with all these PPEs was a big challenge for a nurse to write. And these PPEs, this mask would generate the fogs, which if it was not tightly fit, so then that fog would cause lot of barrier for them in writing manually when they're writing their notes. They found it very difficult. And so what they did was these masks were taped with lot of cellotape, with lot of tapes, leucopore tapes were used for them, so that there won't be any entry of this virus. That was a fear that we had, and it incurred lot of financial, financial burden on the hospital also. But still, the management was pleased to make sure that all the necessary protective equipments are provided for the healthcare workers, so that they will not fall sick or they will not contract the diseases. Then next is what we had, the equipment that we had was the high flow nasal cannula. That was also a challenge that we had. The nurses were introduced the new type of HFNC which they've introduced. The nurses were not aware of it. They were trained for it, because all these new equipments, and moreover the aerosol boxes were introduced for easy intubation, so that that will not generate the aerosol for that purpose also. So all these are the new challenges that we faced in setting up, in procuring. This procuring was also an issue, because it was during that time that we did not have lot of transactions. We had lot of transportation was not there, so getting the PPE was itself an issue. But at Ramaiah we did not face any difficulty or any shortage of these PPEs. We had sufficient amount PPEs for all the corona warriors, so that they will effectively provide the services to the patients. And the next challenge that we faced was the human resource challenge. As Madam Antonia told, that is the greatest health force. Nurses are the greatest health force, and we had lot of challenges related to the in related to human resource. First one was identifying the pool of healthcare workers. We both, the teaching hospital and the corporate hospital put together, we had all the healthcare workers, but we had to create a pool of healthcare workers who are fit for the working in the COVID wards. We will not be able to make all the healthcare workers to work in the COVID ward, because they may be suffering from a lot of comorbidities. Age is also a factor. We have a lot of people who are above the age of 50, so they cannot be given the responsibility of working in the COVID ward. So we had to first categorize them as fit and unfit. So fit categories are those people without comorbidities, with below the age of 50, and they will be able to function. So they have to go through a long process of medical checkup with lot of investigations. All this was literally done in the hospital to make sure that the nurses who work are fit, and also that will not be in a way for them to contract the disease. All the unfit nurses worked in the non-COVID areas, so we categorized the employees. That was a greater exercise that we did, and we had to, even healthcare workers who are pregnant, lactating mothers, they all were not allowed to work in the COVID area. So we had a very small pool of healthcare workers who were fit to work. So this was a greater exercise. So that was one of the challenges that we faced. And moreover, when during the normal days when they were working, they used to work 12 hours of night shift. But then when this COVID period came, because of the PP that we were working, they were given 6 hours of duty. So when we made this 4-hour shift, 4 shifts, morning 6 hours, evening 6 hours, N1 is for the first 6 hours and the next 6 hours. So we need more number of employees which had to work. So they had so many times of rounds of duties that they had to do. But we made sure that they are being scheduled in such a manner, and they had to work for, initially we thought that they can work for 10 days, but that was not possible. It was difficult for them. Then we changed it to 8 days. Then we gave a quarantine period of 7 days. So during this quarantine period, they are being given, even when they work, they are being given facility in the hospital itself to stay there and work. And also the 7 days of quarantine, also they are also before they were, when we did not have facility in campus, we had hired the hotels, and they were staying in the hotels in single rooms. The management did a lot of things for the employees there. They worked for, they stayed for 7 days as quarantine, and on the 6th day, the swab test or RT-PCR test was done for all the healthcare workers, and based on their result, they would be either be admitted or they would go back home or get back for work. So this facility was also done, but that that was a big challenge for the nurse administrator, because we need to schedule the people, we need to have the pool of healthcare workers who are working. Some may fall sick during that time, many may get admitted during those days. We, as of today, 100 of our nurses were admitted as positive cases, and we lost one of our precious nurse also during this pandemic, which really heartens us. But then actually she did not work in the COVID ward, she worked in the non-COVID ward where she had contracted the disease. But still, we made sure that we had challenges, but we made sure that facilities have been provided. Quarantine facility was a big challenge. During the initial days, I remember those days, it was in, I cannot forget the date also, it was in July 27, when all our nurses were shifted from here to a different facility. The residents came out, they did not allow them to occupy those hotel facilities. They were shifted from one place to the other, one place to the other. So lot of, mental challenges they had to go through even during those times. So we now host them in the in-campus area so that they will be more comfortable, and they will be able to provide better care. And managing these challenges during the quarantine, we provide all the food facilities for them, the facilities for showering, scrub suits we provide them, so that if they stay here, leaving their home and coming here, so we provide them all the facility that was required. And in order to coordinate with the patient and healthcare workers, we have the social workers department, security department, all this was kept in place. So security was also an issue. Most of the people were not ready to work as security people because they were scared, because during this pandemic they may contract it. So all these challenges of human resource we faced, but then we can say that we win. Actually we win, and we did a lot of things, a lot of protocols we was in place, and we kept all these challenges, we kept on overcoming all these challenges, and we were able to manage that. And deploying a housekeeping personnel was also a very, lot of outsource agencies, people came and told that we will provide the housekeeping personnel, but we had a lot of issues related to them. Language was an issue, and their culture was an issue when they stayed here. Food problem was an issue, accommodation was an issue for them. And we had health issues during the COVID duties. Many of them had a lot of dehydration, retention of urine, menstruation has already been mentioned. That was also an issue that we faced. There were staffs who were suffering from back pain, and many of them, what we saw is many of them had swelling of the lower limbs, and many had turned to the arthritic pain of the joints and all post COVID. So even during the post COVID, we do not take the staffs immediately after their duties. We ensure that they go through the flu clinic, they get themselves until they are fit. We do not take them back for their duty. So they do go through a procedure, lot of procedures they go through. Post rehabilitation centers are there in place, wherein they provide what are the exercises that they need to do. Assessment is be done, they have been evaluated then only. We had lot of issues related to vomiting. They feel very suffocated and they feel this nauseated. And these are some of the issues. They come back early from their work, so that had to be managed or shared by the other nurses. That we cannot give more number of nurses, because again that can lead to the shortage. So then that had to be arranged. So all these challenges we maintained. Maintaining of attendance was also an issue. They were not made to punch, because that can be a source of infection. So facial recognition of attendance was maintained, so that will not lead to the spread of diseases. Relieving staff from the duty in case of any emergencies, like death in the family, or it can be some other issues which occurs, sickness in the family or somebody, we need to relieve the staff. So we need to arrange an alternate for that, all that. And attrition was also an issue that we faced. We had quite a number of nurses who left during this time, maybe because of they were not able to take up this challenge, or maybe because of the pressure from the family members, or some even for the better opportunities also have left the institution during this time of attrition, which has caused us a greater challenge in managing the manpower.
May I request to maintain the time frame if you can hurry up with some of the slides, please?
Sure, definitely. Okay, the mental challenges that we had was huge workload for the nurses, the fatigue, and the spread of infection was also a concern, and frustration over the death of the patients. When they hear about when they see so many deaths happening, they get really frustrated. Additional responsibility they have in taking care of their families, fear of contracting the disease, anxiety, and some of them had insomnia. All these were some of the mental challenges that they face. Even nursing and education, this was in the service side. Education also had lot of a lot of challenges that they had to face, since the lockdown had turned into learning moved from classroom to online, and lot of the challenges that the students face, that many may not have the internet facilities, and it was a financial burden for them to have the laptops or internet connections, smartphones. Practical skills were not imparted via online training. So exams we postpone. Again, we don't know how the students are promoted without the exams being conducted. So all these are the challenges in nursing education also. So the streamlining, adaptation, and even in nursing research also, we do not have a lot of studies which are conducted. So again, that is a challenge. Now I'll explain, with just these few slides, that when we had to build those dedicated hospital, we had to vacate the existing hospital, the OPDs, the operation theaters, the ICUs, and shift all these, these cots, literally these cots and all that, to the dedicated hospital, and that had to be done physically. Then arranging of logistics like placement of hand sanitizers, signages in all the areas, UV chambers for disinfections of the healthcare workers, mobile phones for dedicated, which for the COVID health workers. Then training, I already told you. So what we did was, schedule was made, videos were shown, demonstrations were shown on the job. When there was any troubleshoots which were there, that time also training was done. Orientation was also given to the COVID hospital. Then, we set up the RT-PCR kiosk. We had a lot of challenges in how to do that, how to create an SRF ID, that is specimen referral form, how to maintain the records, how to dispatch the reports. All this was put in place in course of time. Then setting up a triage area. Initially, the triage area was not there. Then we initiated the triage area, where patients will be triaged before they enter into the wards. At the triage area itself, blood samples will be collected, radiology services will be done, and then only they will be transported to the ward, so that the patient care is not being compromised. Linen management was an issue, because we had to decontaminate the infected linens. Supply of linens was an issue. We had to purchase more linens and stock maintenance. Dietary was an issue. Patients, they don't like hospital food. So they were not very happy with the hospital food. So we had challenges telling that we'll bring food from home, which was not allowed, because that will be again another challenge. So dietary services was actually a problem, but we faced it. Then transportation for external. For example, in case of patient, we have the X-ray machines inside, but in case if a patient requires a CT scan, patients had to be moved out of the hospital. So training had to be done as to how to arrange for the ambulance, how the patients has to be transported, what are the disinfection protocols that has to be maintained. Maybe a patient has to be requires an operation. So when we move to the operation theater, how it has to be moved, what is the protocol to be done, all this was a big challenge. So as a nursing personnel, I can really tell that we face a lot of challenges, but ultimately we can say that a lot of lessons to be learned. We have, kept up the team spirit, and we were able to win, because we were able to put a lot of things in place. So I would like to thank IPC Health and all the team members who have given me this opportunity. Thank you.
It was a very great journey, ma'am Lizzie. It was so beautiful. So everything, you just took us through what are the challenges that you went through. And as it is said that only storms create great leaders, not sunshine. So thank you. Now I request Madam Akkama to share her views and her topics. Thank you, Madam Lizzie. And I hand over to Madam Akkama Abraham.
Thank you, ma'am.
Good evening to everyone. Thank you, Ma'am Antonio. I'm Akkama Abraham, General Manager, Nursing Services. I belong to KIMS Health Trivandrum. KIMS Health Trivandrum is the flagship hospital of KIMS Health Group, and this is a tertiary cum quaternary level healthcare hospital, and with 500 beds as of now, and it will soon be 750 beds when the new tower is commissioned. Our workforce includes around 750 qualified nurses with around 250 nursing supporting staff. Today, let me share my experience in KIMS Health related to the COVID management. It was certainly a learning curve for all of us since the disease condition was very much new to us. In Kerala, COVID patients were initially admitted only in government hospitals, but we were sure that there will be a time we also will have to admit cases in our hospital. So we prepared in advance our COVID preparedness plan, and that was required as we consider our human resource as the most important asset. And it was determined that any implementation of business continuity measures are to be, are to be very much supportive of our staff. Also, we wanted to ensure that there is an actively functioning supply chain and its flexibility to bring in additional equipment and products if required. Also, we wanted to ensure that our essential services are not suffering because of the unforeseen demands brought by COVID-19 cases. Once the plan was ready, then we had to do a readiness assessment before start admitting cases in the hospital to evaluate the hospital's capability to safely identify and effectively isolate a symptomatic patient at the facility. Now, who is going to lead the program? So the management has decided to formulate a task force, and it was named as Core COVID-19 Management Task Force, or otherwise known as CCMT. By coordinating all relevant stakeholders for it, like leaders from medical services, nursing services, purchase department, and clinical engineering, operation facility, etc., etc. The committee used to meet regularly, almost on every single day, and the main agenda was on epidemiological analysis, statistics and update, risk assessment and mitigation, notification and communication process, and strategies for optimizing supply chain management. Now, the policy manual actually establishes the boundaries, the details, the guidelines, and also communicates the best practices nurses have to undertake. So we also prepared our COVID-19 manual, customizing all the guidelines from national and international bodies, and we formulated around 50 SOPs and also made that available in the intranet for the staff to access it at their own convenience. A triaging system, a screening clinic is established at the entrance of the hospital itself so that the exposure to COVID-19 is minimized within the hospital. The triaging is done based on the acuity and based on ventilation capacity. Once the patient is moved to respiratory ED, the categorization is done. There are 3 categories, A, B, and C. A more with the mild symptoms, whereas B is with more severe symptoms and with one or other comorbidities. And a patient, a vulnerable patient, if he acquires the COVID-19, these all come under the category of B, and category C is with more deteriorating conditions like breathlessness, falling blood pressure, etc. Categorization should be reassessed every 24 to 48 hours for category A and B. Once categorization is done, the management, category A more with strict home isolation, but B it depends on the clinical assessment. It can be either admission or strict home isolation, but C certainly requires hospital admission. And if the patient is prone to undergo any aerosol generating procedures, then they will have to be in the airborne isolation with negative pressure. We have extensive diagnostic testing facility, and we test here for both to detect the infectious stage and also the immune response. There are 3 tests done. One is molecular test, antigen test, and also the antibody test. Molecular test, otherwise known as NAT, RT-PCR, etc. And what specimen is required for each test? For molecular and antigen test, nasal or throat swab is required, whereas for antibody, we need finger stick or blood draw. How long it will take to get the result? For both the molecular and antibody, on the same day itself, the result will be out, whereas for the antigen test, less than an hour. What it tells us, what's the result tells us, for both molecular and antigen, it diagnoses the active coronavirus infection, whereas for antibody, it detects the infection by coronavirus in the past. We are very much familiar with all preventive measures, so I'm not going into details of any of these slides. The biomedical is properly segregated, collected, and transported to the destination by wearing the protective gear meticulously. Linen management, the same thing. This also has to be treated with 1% sodium hypochlorite solution before it's put into the liner, plastic liner, and secure it and put it in the yellow hamper. Okay. Once the case is confirmed to be positive, then all the precautionary measures are to be taken for the patient movement from one place to other. The communication and implementing controls, once the information of positive result is reached to hospital infection control from microbiology department electronically, it becomes the responsibility of the HIC to inform the patient if OPD case, if IP case, to the concerned area staff. And from there, the decision will be taken either to be admitted or to be sent home for home isolation. Reporting takes place both internal and external, internal to the clinical administration and HIC, whereas the external reporting is to DMO office, collectorate, and local PHC and local police station. What to report, all the details like number of COVID cases, the ICU status, how many patients are there on oxygen therapy, and screening, the details of screening, clinic tests, etc. Now, the occupational risk pyramid, actually 4 levels of risk, and they are categorized and in the shape of a pyramid. The very high risk is the smallest population, and healthcare workers who are assisting in aerosol generating procedures or lab staff, aerosol generating procedures like intubation, dental exams, or bronchoscopy, lab staff who collects and process the specimens, high risk for patient allocated staff, ambulance staff, burial workers, etc. And also medium risk for staff with close contact within 6 feet with positive SARS-CoV-2 patients. Low risk means no contact neither with SARS-CoV-2 or with COVID-19. Now, once it's at this point of time, it's almost impossible to eradicate the hazards, then we have to implement certain workplace controls like safe work practices, use of PPE, engineering controls, administrative controls, etc. Safe work practices, you are aware about it. PPE that has to be selected based on the hazard the staff is going to have. And it has to be properly fitted. If we use the appropriate usage, if we maintain the appropriate usage, you can have zero wastage of resources. Engineering controls includes all high efficiency air filters, negative pressure, additional exhaust fan, etc. Administrative controls like symptom checks, it's nothing but the team leader find out or inquires the health status of her teammates in the beginning of the shift itself and document the same. Ensures the sick staff stay at home. All meetings are replaced with virtual communications. All policies like work at home, reserve food policy, employee health are all implemented. Now, the discharge criteria for asymptomatic patients can be discharged on the 10th day when the antigen test becomes negative. And for category A, discharge if completed 14 days since the onset of symptoms and antigen test is negative. Whereas for category B and C, the discharge if completed 14 days since the onset of symptoms and no symptoms since last 3 days. Irrespective of category A or B or C, they are advised to avoid non-essential travel and social contact for 7 days after discharge. Partners, we have a lot of data and documentation available, and we have initiated further studies and research. And after the discharge, patients are all referred to our post-COVID wellness clinic where they will be taken care of. If patient died, then we have to take care of the dead body as well. We have to spray 1% hypochlorite solution before putting the corpse wrapped in 3 zip-locked plastic covers, and the terminal care again with 1% of sodium chloride. Now, the next topic is HR management. Preventing COVID-19 infections among healthcare workers is critical for their safety as well as for the stability of healthcare delivery system. The major goal of having a robust HR management is to establish staff safety, optimize staff scheduling, and build resiliency in the team. Now, as part of the staff planning, we had to determine the capacity volume of the facility so that we can determine how many additional nurses are required in each facility, plus also the core skills required to take care of those patients. Because of the attrition rate high and the increase in patient census, designing and redesigning of workforce was required to be done on every single morning, and that was a Herculean task. Sources of additional staff, the staff who were assigned in non-clinical areas like training and education, etc., were brought back to clinical site. Now, as I said, because of the shortage and because of the shortage of staff and because of the increased number of staff, we had to establish a very scientific and reasonable shift schedule in order to reduce the resource consumption. I mean, for example, if a nurse is advised to do 2 broken duties of 4 hours, then she will be using 2 sets of PPEs, and that increases the resource consumption. If frequently moving from COVID area to non-COVID area, that can increase the risk of infection, and frequent donning and doffing also can increase their mental burden. So considering all these problems, we opted 6 hours continuous shift for 7 days with next 7 days as quarantine leave for nurses working COVID areas, and for nurses working in non-COVID areas, 12-hour shift means 4 hours duty, and with 3 days off per week. And we found that that shift schedule was working well with us. Challenges in staffing were absenteeism and unpredicted sickness, and because of that, many times we found that though we have encountered many excellent staffing formulas, but because of these unpredicted situations, we had to we found those formulas not very practical on many days, so we had to rely on our professional judgment. Now, we have to have a plan B always ready, and our plan B actually was to make some modifications on the facility itself. If a ward doesn't have many patients, then that can be closed down and other areas can be merged, even early discharges with free home health care service. Staff engagement, these are so many things which the other panelists have spoken about, like identifying staff concerns and addressing them. This is something which we wanted to comment. We have an excellent team of nursing leaders who are trained nursing counselors, and they are called as Blue Volunteers, and they go around and they coordinate with other nurse managers and identify the staff concerns and address them. To improve the staff morale, I say that that's only one way, that they have to feel that they have somebody to listen to them, and now we should learn how to accommodate others. And we do courtesy calls of telephone calls continuously while staff is on either sick leave or quarantine leave, to know about their whereabouts. Staff exemption was mainly for the vulnerable group, means nurses with advanced stage or pregnant ladies etc. were exempted from COVID duties. Paid quarantine leave, if the quarantine leave was like a nurse, one of our patients turned positive and she was advised to go on quarantine leave, in that case, that quarantine leave was to be considered paid quarantine leave. The management has ensured that health insurance is there for all nurses, which was a great blessing for all of us. And regular checks of symptoms. And here comes the COVID and non-COVID duty rotations. When they come back after 1 month of duty, that is 14 days work and 14 days of quarantine leaves, they are assigned in non-COVID areas. 30% of reserve pool was maintained in areas where the core skills are required, like operation theater, NICU, bone marrow transplant unit, etc. We have documented and updated the nurses' personnel file in such a way that everything like their training merits, their appreciations, recognitions, etc. were updated so that it can reflect at the time of their performance appraisal, and also to mention it in their experience certificate when they leave. A word of appreciation, and this is the time I would like to thank our beloved chairman, Dr. M.I. Sahadullah, because he truly believes in nursing empowerment and wholeheartedly supports all the nursing endeavors. Also for the organizers, the moderator, my fellow speaker, I thank you all for this wonderful opportunity to participate in this platform. I thank my office staff, Ms. Sarida, and all my friends for their clerical support. Last but not the least, I want to thank to all the nurses. I salute each one of them. My gratitude and appreciation for putting in their absolute best in this battle, despite of all the challenges and struggles that come their way. Thank you very much. I hope that I haven't taken a long time. Thank you.
Thank you,
very
Madam
much,
Akam.
ma'am.
Yeah.
We will take about 5 questions. Antonia, ma'am, request you to please take it forward.
Yeah, sure. Thank you so much. That was a fantastic journey of both, renowned institutes in the renowned healthcare institutions in the country. So I have, a few questions. Madam Lizzie, the first question to you is that how to combat the feeling of inefficiency, especially when you don't see any progress in the patient that, a nurse treats?
Yeah, I don't think that the nurse should consider themselves that the work that they do as inefficient. So we need to instill the confidence in them that whatever that they are doing is efficient. You are efficient and you will be able to do. So that type of positive attitude can be instilled in them so that they'll feel better and this when the progress of the patient or the condition of the patient does not depend upon your efficiency. It depends upon the condition of the patient also. That can also be, explained to the nurses that the comorbidities, the age can be a factor, the disease process itself can be a factor, the immunity power of the patient. All this can lead to the deterioration of the condition of the patient. So the nurses should not feel bad that they are inefficient. That is why the patient's condition is not being progressed.
That is very well answered. Madam Akama, you said that during the COVID time, the nurses, who were in the non-clinical area, you had to redepute them or reallocate them into clinical areas. But training also is, one of the important key achievement of, KIMS. So how did you manage training challenges during this COVID time when you had to shift the nurses, from non-clinical area to the clinical area? You are mute, ma'am.
Thank you. Yeah, okay. Actually, our training man-hours comparatively to the previous year is very much down this year due to COVID-19. Means in the beginning times, I mean, we couldn't go ahead with very formal training sessions. But we were in the beginning, we were not very familiar with Zoom or Google Meet. And what we were doing, like recording the videos on certain procedure, like donning and doffing of PPE, taking care of patients on prone position, etc. Such topics were video recorded and forwarded them to staff WhatsApp so that they can access that and they can watch that. Okay, that was the kind of training we were doing in the beginning. And later we replaced all classroom sessions to virtual platforms. And that also, again, in the beginning, nurses were not very receptive of those platforms, but with a lot of encouragement and talk, they started accepting. Now it's going on very well. There is no problem, except in hands-on sessions. Hands-on sessions, it's difficult for them, on platform, virtual platforms. So with the social distancing and all, especially like for sessions like BLS, ACLS, etc. There was a time we used to have 25 candidates for ACLS session, whereas now that is with 8 to 10 candidates in a session. So we will have to continue, repeat the sessions very frequently.
So very good, great strategies that you had adopted, and for that change is always resisted. But at the time when it comes to change, which when it moves from change to transformation, nurses really they have done so well, and congratulations. And we also have a lot of learning lessons from you, Madam Lizzie. I have these questions for you because COVID continues, and we do get though the cases are declining, but we have nurses taking care of the patients, and also they are going back to the family. So always that apprehension remains whether I'm carrying the infection to the family. So what should a nurse to keep in mind that her family and she is safe from getting and spreading infection from the hospital to the family members?
Okay. In a hospital, what we did was we ensured that they are in-housed before, and once the test has been done, only then they get back home. But it may not be the situation elsewhere. So taking care of yourselves with the appropriate PPE, with the resources that is available is very important. And to have shower before going also is a very good idea. So that can also decrease the spread of infection. And not only that, frequent washing of hands, all these disinfection protocols, if you can follow, then definitely, definitely that will not lead to the spread of infection to the family.
Okay, that's beautifully portrayed. Madam Akama, I have this question. This COVID has made me to be an isolated human being. But I'm a human being, one who is social and also, one who is emotional. And I really would like to have, great contact, with my other fellow beings, nurses, professionals, maybe at home also, and the hostels. So nurses, they occupy a larger space in any hospital. This quarantine also, you had to do a lot of quarantining for nurses. How did you engage these quarantined staffs during that quarantine time, the staff engagement?
Okay. We had totally separate hostels for positive nurses, COVID positive nurses, and also for those who are on quarantine leave. And there are certain things which can actually reduce their worries and tensions. Like if they come to know that the days they are going to stay at home as on quarantine are going to be paid leave. Okay, and if at all they get positive, then they will be taken care in the hospital by the insurance. So these things can actually relieve their stress a lot. And as I mentioned in my class, in my presentation, our blue volunteers, excellent people, they were actually in close contact with them. So to release their stress and to release their anxiety and all. And we also provided them very nutritious food and hot water at their convenience. and essential services like charging the mobile SIM, etc., were all done for them because they cannot go out. And if they needed transportation facility, then that be provided for them to come to hospital to do the lab test and things like that. So that in many ways, I mean, we supported them. We never left them to feel that they are all alone.
That's a very nice, humane approach to keep, people engaged, even though they are quarantined. And such a humanitarian sort of like approach you have taken. Hats off to Kim's management. And we had lots of, even the world had lots of lessons to learn from state of our Kerala. It became, our Indian pride because how you managed, the cases in Kerala, it itself, a case study. Thank you for sharing those very good, inputs, ma'am Akama. Madam Lizzie, I have this question to you. When I am providing, you were very sincere enough, genuine enough to tell you that though you had the ventilators, but you did have the inadequacy in training those nurses in but accepting that is one. Next one also, this inadequacy of resources might put the nurse at risk. Also, she might feel that because of this inadequacies and inefficiency, already you have answered in the previous question. So inadequacies of resources and also inefficiency in her case rendering, how that might affect a nurse when it comes to her licensure and accountability towards good patient outcomes.
Okay, and now I mean to say they were not inefficient, or they were not. It's not that they were not available. They were the nurses who were working in the ICU. They're very much well versed with the ventilators, but the new ventilators which come add little options which they need to know. So that had to be trained. So what we did was, we, as Madam Akama told, we put it on their WhatsApp group so that everybody can view the demonstration, how it has been and how it has to be used. That is one way. So definitely that will help them to be more accountable, and also that will not make them feel that they are providing substandard care. Okay, but this substandard care can affect the licensure also. Initially, when I was a student, it was a lifelong license that we had, but it is no more like that. At present, it is every 5 years that has to be, and we have to show a record of the CNEs that has been conducted. All this is put in place. So definitely, I'm sure that the nurses are more accountable, and they make sure that they're well equipped with their knowledge, skill, and attitudes.
Okay. That's very beautifully answered, Madam Lizzie. Madam Akama, I have this, when it comes to the interaction between the staff, nursing personnel, because they are the frontliners, right? And they interact, with doctors, they interact, with community, they interact, with patients and families. Sometimes the social distancing also, also that is one side. Your protocols one side. The second one, the love of the family members, and in between, the nursing staff and the frontliners come. So a lot of visitors in the hospital, and they have to go through, in every situation you have, screening, you have preferencing, you have triaging, admitting, counseling, deciding, resourcing, notifying, anticipating, grieving. Every time, the nurse has to communicate with the patient and the family members. How did you manage visitors when they were really, emotionally charged?
Um, I think, Ma'am Antonio, nurses are the best. I have to say about the visitors policy. Once the management had decided to start admitting COVID patients in the hospital, that before start admitting, the visitors policy was revised, that no visitors will be permitted for COVID with COVID patients. Okay. And the non-COVID patients are also to be admitted after doing the lab test. Okay, and the bystander, one bystander only is permitted, and that bystander also will have to the certificate with them saying that the COVID test is negative. And in case after 2 or 3 days, if the visitor, the bystander turns positive, then a second bystander will have to come and attend the patient. And this type of restrictions were already there on bystanders and visitors. Uh, Kids were never allowed otherwise also to visit patients in the hospital, so that was not a big issue. And the second part of the question, as I understand, you are talking about communication, how the nurses.
No, no, I said
Oh,
that
that's
already.
total.
You have answered. You have
Okay,
answered the
okay.
question. You revised, and
Yeah.
also, nurses could handle everything, and you had, good strategy at place. You answered, ma'am.
Okay.
Madam Lizzie, this is, like when a nurse goes to the, it is not only nurses are everywhere. They are, everywhere. When I say that, when it comes to home healthcare nurses, though we have lot of protocols and all, you also have that wing, and how what are the precautions that home healthcare nurse should follow when she is caring for, because now many organizations, they have taken this home, I mean, what we can call myotherapy, or like domiciliary therapy, or maybe the home therapy, home treatment packages were given for the public to avail from various hospitals. So the nurse had to visit their family and all. So during that time, to be more specific, what are the precautions and care strategies that nurse had to adopt?
Yeah, home care is the boom now. If in our hospital also, we have, especially for collecting the specimens, we have the home care services that are being put in place. Whatever it is, we do not know the condition of the patient that the nurse is going to treat. So that case is always a suspect case. So she should take care of herself in such a way that she will not, in any way combat the disease. As usual, wearing of mask, wearing of face shield, PPE kit, and hand sanitizers, washing of hands. All this same protocol has to be followed when it is for home care also.
Okay, that's a very nice thing, and we have, a very good friend, Dr. Rajiv Chore. He is actually writing it from Care Hospitals, and a great administrator. Thank you, Dr. Rajiv, for logging in and asking this question, Madam. This question is to you, Lizzie. How are you managing nursing shortages? This is what Dr. Rajiv Chore is asking from Hyderabad.
Yeah, and nursing shortages, not only in India, it is an universal problem. Okay, there are so many ways which we can combat. One is we need to understand what is the cause for the attrition. What is there anything that has to be put into place so that the attrition can reduce? And in case of shortages, incentives can be provided. We make them work maybe a little extra, and then provide them the leave benefits for that. Stagger their duties, that also can be done. And financial benefit is the best option. Even in a country like US is doing the same thing, that when there's a shortage like that, and immediate recruitment of trained nurses also can be another option.
Okay. Very nicely answered. So, but Madam Akama, you said that during the COVID time also, you could have nearly 30% of staff reserve in special critical areas like NICU, PICU, and you had your CCU, ICUs, and all. And that having 30% reserve, how did you manage? According to Indian Nursing Council, we have our advisory, and KIMS and both Ramaya hospitals both are very long-standing great institutions holding NABH accreditation. So when it comes to nurse patient ratio, during COVID time, it's a curiosity to me to ask you this, how you could manage this type of staff ratio. Did you have any strategy, Madam Akama?
Yes, we had. In my presentation also, I was mentioning about the staff safety. Yeah, that was our priority, for one priority in KIMS Health. So even there are step-down ICUs or ICUs where we haven't utilized all the beds available, only because we wanted to reduce the viral load. So because if viral load is increased, that is not safe for staff. So we were, our hospital is a private establishment, but still the management took care of their staff and doctors in such a way. Okay. So saying that, when we had to maintain 30% of reserve pool, this is how we did. We did some sort of modifications in our facility itself so that we could maintain that 30% reserve pool.
Okay. And it's a great interaction, from our participants. Dear participants, continue to, post questions. Really, they are motivating us also. And thank you for your interactive questions. And I have a question from Dr. Panduranga. He is asking, Madam, this question is to you, Madam Lizzie. How COVID will affect the nurses who are working as a community health workers in health and wellness center?
How, yeah, how it will affect, you mean to
The
say?
nurses who are working as a community health worker, like nurses, who are working for that matter, like, in community, not only nurses, even our ASHA workers work,
Yeah.
and, people from Ministry of Health and Family Welfare and different, in PHCs and all people are working, and also, in wellness center. So how COVID will affect such type of healthcare personnel as frontliners?
Yeah, COVID is pandemic. It can affect anyone. One thing what I can tell you is the ratio of nurses who were affected in post-COVID duty was comparatively less than the nurses who worked in the non-COVID area.
Okay.
Okay, so that is really, very promising, because PPE, if you wear and if you follow the protocols if effectively, then definitely you can keep yourselves, whichever worker you may be, you can keep yourselves away from this contracting this disease. Because since these nurses were working inside the hospital with the COVID patient, the ratio of patients, the nurses who have contracted the diseases are less when compared to our nurses who have worked in non-COVID area, because the protective equipment they are not been wearing is different from what they are wearing. They are not wearing that full suit. So this can help when there is a pandemic. We don't know who are the positive cases. So it is always better to have a PPE kit and work on shifts. I know our Indian scenario wherein we have shortages, but then still protecting ourselves is very important. Safe distancing and hand washing and hand rub facilities.
That remains, it is like, clean. C is
Correct.
not only for China, Corona, whatever, the virus, and but also, C means your clean hands and, covered mask and cleanliness,
Exactly.
communication, collaboration, everything. So it was a great interaction between Madam Akama and Madam Lizzie. I'm really, delighted. It was a great conversation, and I want to thank the participants also. But before I wind up, I hand over the session to Mr. Vinay. I would like to tell that this COVID has taught us many lessons, our dear friends. So it has lessons learned community, and also, the lessons what we learned, and also, how we have to carry out. There is always, there is a silver line. Every cloud has a silver line, but COVID also, brought a lot of good lessons for us. Just trust, it made us, to trust here and now, mindfulness, enjoy life, appreciate life more and more, to value, small things became very, very important. Our meals, with family together, and, maybe a chat with our friends. And every cloud has a silver lining, as I said. What matters at the end is only good health and, good human connections. That is what COVID has taught us. We need to be thinking of the worst, and, then we prepare, means, whatever adversity comes, surely that is going to combat, any adversity. And this adversity has taught us that we all are one in this fight against corona, whether it is not just, nation or community. We all have come together globally as one human family. Nature, we understood how nature is so powerful. Time to review, but also, time is a healer. But this time has taught us greater lessons. So let us learn from there. And there is a huge reorganization of, health services, lot of, reformation in health policies, and people became new wards, are set up now. And not only people became very clean hand consciousness, but also, we healthcare workers also, became so much infection control practices oriented. I think both of you would agree with that. And as the cases, they continue to fall, really, we hope we shall march towards as one, human race towards a brighter future. Nurses, who are working in the emergency care and cancer care and all, they are resuming to their duties back. So we are evidencing enhanced health behaviors, physical distancing signboards. Diwali is coming, so let us stick on to, whatever the protocols that we are following, and various, hygienic practices we need to understand. Let us also, make it a point that managing people For leaders, managing people is very important. Default to kindness, to be kind to one another, to show that empathy and kindness, not only to patients, even, kindness towards oneself and also, towards the team. And one size does not fit all, but one person, can multitask. That also, can address human resource shortfalls. And hiring, wisely right talent for right job, that is very important. Conflicts, in a lot of conflict resolutionary and leadership skills. And we need to speak and start, doing these experiences and experiments for future, learning purposes. That would be very nice. So I want to thank Dr. Renu and Mr. Varun and her team for giving us this opportunity on behalf of my co-panelists, Madam Akama Abraham and Madam Lizzie John, respectively from KIMS and MS Ramaya. It was a great interaction with you, and also my sincere thanks to all the participants and people who worked at the backstage. So thank you so much, and surely wish you a very, very happy nurses year ahead. This is really our year. So let us make, we shall win, and we shall overcome one day. Thank you. Thank you so much.
Thank you so much, Antonio Pushparaj, with your wise words of wisdom. Thank you to our panelists today, Akama Abraham, Lissy John, to all the team members from IPC Health, and most important, thank you to all the participants who were listening to us patiently from the last 2 hours. The questions are still pouring in, the emails are pouring in. IPC Health and Impulses will continue to host many more webinars which will be relevant to each one of us here in the medical profession. We thank you all sincerely. And with the upcoming Diwali festival, we would like